So let's just take a step back and think about what's good about the model. And the good thing about the model is it really does start to discuss the concept of transforming the delivery of care and making physicians accountable for the delivery of a certain type or quality of care. My criticisms of the model are that it's too prescriptive.
Too prescriptive, absolutely.
Just too prescriptive. And so, you know, I have oncology medical home relationships with 15 or 16 practices. I'm starting to build them actually with integrated medical centers, NCCN institutions, in fact, and about the concept of continuous quality improvement, measurement of performance, considering the patient experience, all that stuff. So the problem is you have to do A, B, C, check these boxes, and then you don't know at the end of the day whether you can get paid or not. So we have a much simpler model. And right now what I'm struggling with is will CMMI let me do my model in their program, or do I just say, see you guys, I got a system, I'm doing my thing.
That's what we
And
do.
I don't know what the answer is yet. So it's very interesting because there was a lot of discussion about why CMMI delayed the LOI deadline. And I think most people concluded that the payers just didn't know what the heck to do with this.
No one's coming to the party
and
yet.
So we've been on record that we're
Right.
going to submit the LOI.
Right.
We are not on record as saying that we will
You're gonna
submit an
submit the binding
application,
application,
because there's going to be
Right.
negotiation.
Right.
There's going to be discussion.
Right.
And I think at the end of the day, the worst thing for CMMI is if they threw a party and nobody came.
Yep.
That would be totally destructive. Now, the flip side of that is from the practice level, and I don't want to be too harsh, but for a lot of practices, they're looking at that $1,000 a patient for 6 months, and they got dollar signs in their eyes because they got all these Medicare patients. That is just the wrong way to look at it. This is, if you're starting from scratch, you're going to lose money doing this. And if you're already partially transformed, it's break even. Maybe the really sophisticated practices will make a little money. Forget about shared savings or gain share, whatever the hell you want to call it. I don't think that's happening.
Right.
Not the way they build it. And I have said
Right.
that they say it's a 5-year model,
Right.
but built within that is at the 3-year point, if you
can-
haven't
you can
made
get
any savings,
kicked out.
you're out.
Right.
So everybody's out at 3 years.
Right.
It's a 3-year model,
Right.
not a 5-year model.
Right.
It's a 3-year. And actually for me, that's
It's
good
really
because
a
we
2-year.
won't
Right.
sign on to
Right.
anything for
Right.
5 years.
Right.
But you know, you gotta, I think there's all this discussion and
part of the problem, Mike, is if you're on the practice side and you say, look, we're doing innovative things, like Bruce Gould's practice, for example, we're doing innovative things and participating in pilots, is at the end of the day that they may sign up from the standpoint of saying, well, I'll take a wing because at least there's this $160 fee, and then I'll see, do they come down the road with something? But it's no way to run, you know, a program like this. And to go back to your point, you know, what you're doing on the Oncology Medical Home in Aetna is great, and it's kind of interesting, frankly, because you were the oncologist, the practice oncologist, you're married to a practice oncologist, so if anything, you would be more prescriptive in saying, this is what you want to do, and you're not. You set the parameters.
it's because what Scott said,
right.
Healthcare is local, right?
Right.
Different practices have different structure. And
Exactly. But the point is here, you have CMMI, and you know, that is now dictating medically what you should be doing. In fact, as you know, that we threw them off. We said, look, I'll tell you right now, there are practices that if you make them have a dedicated nurse navigator, that will literally not do it. Let them embody the concept of nurse navigation into their processes. Don't require them to have a specific person. But even now, it's too prescriptive. So that's part of the problem, Scott. It dictates everything.
It's
the government.
Well, that's what you do. I mean, you sit around all day and you make rules.
but the other thing Scott said.